Welcome to the Enhancing Clinical Practice and Outcome stream, SNOMED CT Expo 2022. My name is Yongsheng Gao, Senior Terminologist at SNOMED International. Today I will moderating this session. All questions will be answered at the end of the session. Online attendees, please put your questions in the QA box. And people here, we will provide the mic after the session is finished. I'm now pleased to introduce Zulhairi Mohamad from the Ministry of Health, Malaysia, who will presenting implementing unstructured data analysis for reports in oral health program. Please go ahead. Yeah. Are you ready? Yeah. Thanks.
Good afternoon. Thank you for that kind introduction, Mr. Chairperson. Again, I'm Dr. Zulhairi Mohamad. Actually, I'm a dentist from Health Informatics Center Planning Division, Ministry of Health, Malaysia. Today, I'm glad to present to you and share some experiences on implementing unstructured data analysis for reports in oral health program, Malaysia. As in summary, eReporting Oral Health was developed as one of source system for Malaysian Health Data Warehouse, MyHDW, to replace its predecessor version, Health Information Management System, HIMSS, eReporting. This web-based data collection system was developed to collect granular data from all oral health services at all hospitals and clinics throughout Malaysia. With the integration of MyHarmony to harmonize and codify free text with oral health reference sets and SNOMED CT using natural language processing technique, it enables comprehensive analytics and generate statics, fixed SNOMED report, and also dynamic ad hoc reports in a timelier manner. As an introduction, eReporting version 2.0 Oral Health is a web-based application developed during MyHDW Phase 2 project. It is developed through collaboration between HIC, Planning Division, Ministry of Health Malaysia, and MIMOS as technology partners together with Oral Health Program, Ministry of Health Malaysia as subject matter experts and stakeholder. In previous years, reports from Oral Health Program, In previous years, reports from Oral Health Program arises from manual collection of data from each patient visit to healthcare facilities and later compiled at the clinics or district office as aggregated data. So upon confirmation, the form will be submitted by dental district office by a Health Information Management System, HIMSS, eReporting system, and reports were generated via HIMSS e-form within the existing application-based eReporting system at the dental state office and also Ministry of Health Malaysia. But in recent years, due to system inefficiency, reports were generated manually, which can be time-consuming and taxing on the staff workload. So figure 1 on the left side shows HIMSS eReporting, which is the previous version. Data collected as aggregated data from hospitals or clinics, which then flows to dental district office and then to the respective organization such as state office and Ministry of Health. So on the right side, you can see is our solution for the new eReporting version 2.0 Oral Health. We collect data in a granular form, and this data arises from clinician or practitioner. So to improve the data quality in annual returns or reports, a web-based data entry was developed to capture granular data at the user level, thus generating returns as part of enhancement of the existing eReporting system. Clinician will have to enter the necessary information during the visit and information on every procedure that they have provided in the free text box, which we call procedure description. Subsequently, MyHarmony will harmonize and codify free text into SNOMED CT concepts to generate reports. So these system enhancements include the followings. One, new data source modules, extended privacy assurance service, PAS, extended extract, transfer, and load ETL, integration of MyHarmony, and report generating business intelligence BI. With the availability of a new system, human error and verification procedure can be reduced, thus improving the quality of the report. In November 2021, a total of 20 facilities were selected throughout Malaysia as pilot facility for actual data entry. So from figure 2, we can see that data from eReporting version 2.0 Oral Health consists of structured and unstructured data. So for example, structured data come from promotional modules, fluoridation, and workload for dental technologies. Okay, so we do collect some sort of fluoridation status, water fluoridation status for each states. So for unstructured data, we collect procedure in a free text form. So then this data is securely transferred to MyHDW in a JSON format file. So as mentioned before, this data will undergo PAS, meaning that all the demographic data will be pseudo-anonymized into a virtual personal identification number. And then it will also undergo ETL, and the unstructured data will undergo codification in MyHarmony. And through business intelligence, we create reports in a fixed format or ad hoc report. Okay, so for method and with regards to methods and implementation, we have created about 14 data sources, which we call submodules from primary and also specialist oral healthcare services. So this data submitted is either totally from a structured data or a combination of both structured and also unstructured. As you can see from the primary oral healthcare, there is a water treatment plant, promotions, and also JT, what we call Juru Technology in Malay, but it actually stands for dental technologies. And then we have a patient base, which is from clinics, outreach, and also school. And then we have 8 of our specialist oral healthcare services, which is oral maxillofacial surgery, pediatric dentistry, orthodontics, periodontics, special care dentistry, restorative dentistry, oral patho and oral medicine specialists, and also forensic dentistry. So as you can see here, I already divided either which one is under structured data source and also structured and plus unstructured data source. So this table shows the result on how MyHarmony codifies procedure description of clinical writings to SNOMED concepts and codes. So for example, when clinician writes scaling and polishing, so MyHarmony will codify this free text into SNOMED codes and concepts. Okay, so some of the procedure description written by the clinicians sometimes are not codified. Okay, our report is actually based on mapping of structured data entry and codified SNOMED concept allocated in each column in Malaysian Health Information Framework, what we call MyHIF. For example, for special care dentistry or special need dentistry, services has a total about 31 columns and 27 rows. So for figure 5 shows some example of the mapping of the SNOMED concepts to our report. For example, for column 13, for restoration, temporary restoration, so we map main concept insertion of temporary dental filling and insertion of temporary restoration into tooth with another supporting concept such as tooth structure to reflect the burden of disease, costs, and also workloads. Sometimes we do maps to one, but sometimes in each column there is 2 concepts. For example, in column 12, clinical prevention fluoride therapy, we map topical application of fluoride and also rinsing of mouth fluoride treatment in one column. So this is another example on how patient-based record structured and unstructured data entry flows to our report. So as you can see here, so our structured data for patient-based consists of data demography, names, IC numbers, visit dates. So, and then unstructured data is procedure free text. So when this data and then translated into PAS. So like I said earlier before this, some demographic data, for example, names and also IC number is secret, is pseudologically anonymized into a VPI, virtual personal identification. And then for the free text, we then harmonize and codifies according to SNOMED city. And then it will undergo ETL, and then later through MyHDW platform, we will generate reports either it is in a fixed format or in an ad hoc. So in March 2022, an internal audit was conducted to assess the efficiency of MyHarmony codifies free text using reference set A. Data consists of patient-based clinical data entry from 11 facilities that have oral maxillofacial surgery, oral pathology and oral medicine, orthodontics, pediatric dentistry, periodontics, restorative dentistry, special care dentistry, excluding primary oral care services, and also forensic dentistry, the non-patient-based submodule. So data was obtained through MyHDW, MyHDW MIMOS Business Intelligence Suite, what we call MyBIS platform, and then further analyzed using Microsoft Power BI. So during the period from 1st November until 31st January 2022, a total of 7,531 procedures were submitted. More than 54.55% of procedure description were codified accordingly to current reference set baseline A. So 90.68% procedure in the restorative dentistry specialists were codified, and it is the most codified procedure from all the specialists, while the least was orthodontic specialists, 19.95%. So much of the procedure come from pediatric dentistry specialists, and followed by oral and maxillofacial surgery specialists, 1,846 procedure description, and the least procedure submitted is from oral pathology and oral medicine specialists, 395 procedure descriptions. And then 39 of 717 concepts, which was codified, which consists of 5% that were listed in reference set A, based on SNOMED City January 2019 release, were obsolete when compared to SNOMED City January 2022 release. Okay, figure 7 shows numbers of codified and non-codified procedure by facilities, while figure 8 shows percentage of codified and non-codified procedure. So actually this is from Microsoft Power BI. So if you choose actually here from a different data group, okay, so unfortunately I can't show you because this one is in picture form. So if you have a Power BI, you can directly downloaded from what we call cloud. Okay, so if you choose differently, if you choose different group accordingly, and then this number over here and also over here will immediately change, okay, to a different data group. So again, I'm sorry. Okay, so this one is what we have for Microsoft Power BI. Okay. Okay, again, the same Microsoft Power BI platform that we use. So figure 9 shows some obsolete concept between two different international edition and its example as table after this. So this figure also follow the same principle. So when you tick this one, you can see what is the concept. For example, procedure concepts here about body structure, about 11% of the procedure that we have enlisted in our reference set is already obsolete. And then a bit more on the ethnicity, but actually if you want to know the exact number, you have just to tick here. For example, there is a 20 concepts that were obsolete for body structure, while in procedure, we identified about 15 concepts. Okay, these are some of the obsolete concepts that we noticed in our MyHIF. So we try to map, for example, permanent tooth FDI 11 to this SNOMED concept. But after we compared to the latest version of international concepts, it was obsolete. And then lastly, if you can see here, complete upper denture procedure is actually the concept. The concept is changed to a fitting of complete upper denture. Okay, so these are some examples for obsolete concepts that we noticed in our MyHIF based on reference set A, SNOMED CT January 2019 version, and also to the SNOMED CT January 2022 release. So for discussion, we are unable to access data from primary oral health care through MyBiz platform because of the enormous numbers of procedure descriptions submitted daily. So whereas for forensic dentistry, there was no data submitted. This audit only showed the numbers of codified concept and does not truly represent the report as per SME required, subject matter expert required, since it is dependent on the MyHIF mapping. Among the factors that influence the number of codification are clinician codification, does not align with SNOMED concepts and its synonyms. Apart from that, the enrichment of local terms play a major role in determining the outcome of the report. The change in concept and its synonym also is a challenge, since the reports are totally dependent on concept assigned to respective column. One obsolete concept will affect the mapping of multiple columns for a single or multiple reports. Back in 2019, we proposed mapping of process and procedure for determining reports. Process is defined as the big picture and highlights in the main elements of your business breadth, while a procedure captures those elements and adds more information for functional responsibility, objective, and method depth, according to ISO 9001:2015. So in 2022, subject matter expert has decided a different mapping to be developed in our health information framework, MyHIF. Concepts were mostly mapped to another supporting concept to reflect burden of disease, cost, and also workloads. So some clinical procedures are not mapped to SNOMED concept because it does not represent their workload as shown as this table. So this table shows the comparison of proposed SNOMED process and procedure mapping back in 2019 compared with the current system. Back in 2019, we mapped one clinical procedure to one SNOMED concept. For example, fixed appliance placement for clinical procedure documentation. We mapped to fixed appliance therapy. But eventually, we mapped in 2022, we mapped fixed appliance placement to fixed appliance therapy plus upper and lower dental arch or upper and lower qualifier value, since this represents their workload. So for another example, for numbers of crown issue, almost all of the process and procedure were mapped, but one procedure were left unmapped, since it does not represent a subject matter expert workload, which is tooth preparation. So for conclusion, in summary, with the implementation of MyHDW eReporting version 2.0 Oral Health, it was able to generate reports for structured and unstructured data analysis and disseminate reports to stakeholders in a timely manner. Thus, action can be taken more efficiently. Further, the data is acquired from the source that helps in reducing the data entry and submission workload. Further works include timely revision of reference sets and health information framework. We will continuously improve our end reports through testing, training, workshop, and further expand MyHDW eReporting version 2.0 Oral Health data source from all hospitals and clinics throughout Malaysia. This is my reference. And lastly, I would like to acknowledge this person and individuals which are not listed. Thank you.
Thank you, Harry. Harry is now ready to take questions. And if anyone has questions, then provide the microphone. Mark. Thanks, Mark.
Just one, you mentioned that there are some that weren't codified. And I saw oral health instruction up there. That's, is it because it's not part of your reference set? Because it is in SNOMED.
For codification, we rely on SNOMED city concepts and also SNOMED city synonyms.
And SNOMED.
Synonyms.
Okay.
And we have another column in our asset, which is local terms. So some of the clinician writings does not follow according to the standards that we set in SNOMED city concepts, does not follow the SNOMED city synonyms and also local terms. That's why it's not codified.
Okay.
So since it's not codified, it doesn't represent in the reports. So it's quite.
And the other thing you mentioned was that you about 55% were codified. What were the highest ones that weren't codified? Do you have an idea?
The procedure that mostly codified, it's not mostly codified. Okay, the specialty that procedures mostly codified are restorative dentistry specialists. So they do some sort of special, they do the common dental procedures. So, and then they actually have a specific, they already allocated a team and specify the needs based on their workload. For example, if you want to reflect the costs and also the cost and also the workload for a clinician, for example, if you want to determine caries, so these special teams has already allocated that if you want to capture the workload and also the disease burden, you have to have some sort of post-coordination. Instead of you claim or instead of the data just represent the tooth that is affected by caries, but they tend to go more. They map from the procedure with another procedure. For example, if you have a procedure installation, restoration, composite or amalgam restoration, map to a tooth structure, either 1-1, 1-2, tooth, 2-2, tooth, 2-2, and then they will go further map to tooth surface, either MOD, and then some of the, even for primary care, we do further mapping according to attendance. So either is a new attendance or it's a repeat attendance. So it's actually an extensive mapping. So I think for the restorative, they already understood the system itself. They already was given a second chance to do the redevelopment of the system. So they come out victorious. About 98% of their procedure, which they describe in the procedure text, is codified. And also we expect the end result is as they required.
That was helpful. It's obviously you do things differently there than we do in North America. And so it's easier for me to now understand where you're coming from and why you're having those issues. Thank you.
Thank you. Any other questions? Okay, can I ask questions?
Yes.
I saw you in your slide, you mentioned about inactive concept, which potentially have the impact on your report. Yes, because we are aware of the, the terminology divide, and in particular, there are a lot of good work have been done by that reference group, and so we improve this area of content. So the inactivation sometimes we can't avoid. For example, the duplication. So one concept has to be inactivated, so that another one stay. To cope with those issues, we have enhanced the ECL query language. In the past, you can only just say, give me the sub-concept of this list. Now, actually, you can include the inactive concept as part of return. So that means those inactive concept can be part of a report. When you run the report, you can still get the code. Because those codes are still in patient record, right? Yeah. Even that's inactive, yeah. But you want to count those numbers, otherwise the number just not quite right. Yeah. So hopefully that enhancement in the ECL language would be helpful for future work you're doing. Yeah.
I think just add on that our system is totally rely on specific international edition release. So if the concept is not in that release, unfortunately, you cannot, the MyHarmony cannot codify based on the reference sets.
I see. So maybe we need to provide more kind of help or guidance to see when you do this type of report and how to deal with the inactive concept. Thanks for that feedback. Okay, if no further questions, we will conclude this session, and thanks everyone and have a good day. Thank you.
Thank you.